Hello everyone and welcome to today's class. My name is Raphael. I'm an expert on psychopharmacology. Today's class will be a continuation of my last class on antipsychotics. In my previous class, I talked about first generation antipsychotics. In today's class, I'll be talking about second generation antipsychotics. So second generation antipsychotics have replaced first generation antipsychotics. Does not mean that the first generation antipsychotics are not in use, but second generation antipsychotics are more frequently used because of their side effect profiles are not as bad as the side effect profiles of the first generation antipsychotics. So let's look at what these medications are. I'll list them here and then we shall look at each one of them. So these medications are, I'll start with the first one. It's called antipine. It's also called Brexam. Then we have quetiapine. That's also called Seroquel. This is a Q. Then we have clozapine. This one is called Clozaril. And then we have asenapine, Freeze. And then I'll use a different color. I'll explain you why. Then here, you should be seeing a pattern there. I'll explain. Then 5. It's called Risperdal. Peridone, called Vega. Then we have 7. We call this Latuda. The Ziprasidone. Ziprasidone. Geodon. And then we have I'll use a different color there. Let me use this. Abilify. Then we have Cariprazine. Cariprazine. Now, these medications, we are calling them second generation antipsychotics. Now, while they are lumped together, these medications are more different than the same. So in this class, I'll be explaining to you why you should choose one over the other one, and why some are not being used, and why some are better than the other ones. So in as much as they are put in one class, they are more different than they're the same. Now you realize that I've been using different color. I can use I've used basic similarities in their name to categorize these medications into 3 groups. Now, you must have noted that there are some that ends with ipine, olanzapine, cipine, pine, pine, pine. And then these ones are ending in don, 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 don. Don, duracidon, yep, don, ziprasidon. This one is ziprasidon, don, don. And then these ones, see this one, the IPRA, PR, PR, PR. Now, these medications, these are some of the facts we need. Let's start with the first ones. The first, ipines, ipines, ipines. Okay? Then we shall look at this later. Let's start with this, the blue ones. So these are the second generation antipsychotics, and as I've said, there are very many. There are very many. They have different side effect profiles. They are more different than they're the same. So let's look at, we have the ipines, we have the IDON, and then you have the IPRA. So let's look at the first 4. Look at the first 4. Now, these are some of the things you need to know about second generation medication. Very, very important. This is high yield. High yield. For example, olanzapine and quetiapine. One thing you need to know about this. 1, they, in terms of, they are weak. They have weaker dopamine blocking effects. That is very important. They have weaker dopamine blocking effect. How is this significant? Remember, for the first generation antipsychotic, we said they have strong dopamine blocking effect. Or we say they are strong dopamine blockers. We are saying these ones are weak dopamine blockers. How is that important? Very important. Lowers risk for EPS. High yield. That's a good thing, right? And that's why they are popular. Because they are weak dopamine blockers, unlike first generation antipsychotics. So the risk of EPS, I talked about EPS, extrapyramidal side effects. When you watch my previous videos, I explained what this means. So weaker dopamine blocking effect, so lower risk of EPS. That's a good thing. Another good thing about these ipines is that these medications interact with serotonin. So how is this important? If they interact with serotonin, it means they can be effective in treating mood disorders. Okay? They can be effective in treating mood disorders. They interact with serotonin, therefore they can be effective in treating mood disorders too, like depression and bipolar disorder. Now, the downside of this, the ipines, is that they are associated with what we call metabolic side effects. They cause metabolic side effects. They cause metabolic side effects. What are these metabolic side effects? They can cause weight gain. They can cause insulin resistance. They can cause dyslipidemia. We have that. So here, when talking about dyslipidemia, it will disrupt HDL, LDL, triglycerides, all that. So, and they can also cause diabetes. So they are known for that. Additionally, they are sedating. So they are heavily sedating. They are heavily sedating. Well, they are good because they don't cause extrapyramidal side effects, the EPS, because they don't completely block the dopamine on the D2 receptors. And also they interact with serotonin, so they can treat mood disorders. But the downside of this medication, they are heavily sedating, and secondly, they are associated with severe metabolic side effects like insulin. They can cause insulin resistance, they can cause diabetes, can cause weight gain, they can cause dyslipidemia. So now let's look at each of these medication. Let's start with olanzapine. Let's start with olanzapine. Let's start with olanzapine. So olanzapine here is also called Zyprexa. Olanzapine is also called Zyprexa or Zyprexa. Well, is very popular, most popular, very popular. But why? Why is olanzapine very popular? Well, it's popular because it's a heavy duty. It's a heavy duty medication. What do we mean by this? It's very, very effective in reversing psychotic symptoms. So very effective in reversing psychotic symptoms. So it's very effective. So olanzapine is very effective. It's a heavy duty. So that's why it's popular. Another reason why olanzapine is very popular is because of its tolerability. So this one, tolerability. Most patients will stay on it for a long time, so patients tolerate this more. So a patient can use this for a long time and tolerate. So because of its effectiveness and tolerability. So that's why it's popular. Effectiveness and tolerability. That's why olanzapine is popular. That's why your prescriber, your doctor will give you that. Tolerability and effectiveness. Now, what is the downside? The downside of olanzapine. The downside of olanzapine is the absolute worst in its class. Absolute worst in its class for causing metabolic side effects. Patients on olanzapine have a propensity for weight gain, independent of caloric intake. And it's not trivial either. Patients have reported weight gain of 10 to 20 pounds, and in some other cases, even more. And the significant risk of insulin resistance, diabetes, and dyslipidemia cannot be ignored. That's for olanzapine. And it's for this reason that some clinicians argue that despite its effectiveness and tolerability, olanzapine maybe should not be our first line of treatment. It should not be our first choice of medication. Well, the jury's out there on that. But at the very least, the patient and the family need to be counseled regarding the potential for metabolic side effects with olanzapine. So because those side effects are not very good, but it's effective. So we're talking about weight gain. We're talking about insulin resistance. We are talking about dyslipidemia. And then we are talking about diabetes. This dyslipidemia, it will have to do with spoiled HDL, LDL, and even triglycerides. So that's about olanzapine. Now let's switch gears and look at quetiapine. That's about olanzapine. Now let's look at quetiapine. It's also called Seroquel. Well, Seroquel is similar to olanzapine. However, it has a few differences. They are very significant from olanzapine. One, quetiapine, it has strong serotonergic effects. This from serotonin. So if it has strong serotonergic effect, what does it mean? It means it can be effective in treating mood disorders. So it can be effective in mood disorders, e.g. depression, e.g. bipolar disorder. Remember when I was talking about olanzapine and quetiapine, I said they interact with serotonin. In that case, I meant quetiapine. It interacts with serotonin, so it has strong serotonergic effect, which makes it effective in treating mood disorders like depression and bipolar disorder. Another thing about quetiapine is that it's a weaker dopamine blocker. That is, compared to olanzapine, quetiapine is a weaker dopamine blocker. So if it has a weaker dopamine blocker, one good thing about this is that no risk for EPS. So for patients who are very sensitive to EPS, quetiapine is a go drug for you. However, because of being a weak dopamine blocker, it may not be effective in reversing psychotic symptoms when you need it. So reversing to reverse psychotic symptoms using quetiapine, you will need, this is important, you'll need higher dose. So as opposed to olanzapine, quetiapine, you'll need a higher dose for it to have an effect on psychotic symptoms. So it will not be as quick as olanzapine in reversing psychotic symptoms unless you give in higher dose. And when you give in higher dose, what happens? You are increasing the side effects. You're increasing the side effects. So that's the downside of quetiapine. Now, another thing about quetiapine is that the therapeutic dose, that's important, therapeutic dose. The therapeutic dose of quetiapine is very sedating. Very, very sedating. The therapeutic dose of quetiapine is very sedating. And it's for this reason that some clinicians will give this medication to patients who have insomnia or who have anxiety on as needed basis. But given the side effect profiles, I don't think that is the best use for this medication when there are other options that you can use for anxiety and insomnia. But in hospital setting, they have the freedom. You'd see patients getting this quetiapine for sleep because it's a strong, its therapeutic dose of Seroquel or quetiapine is very sedating. But I wouldn't use this for insomnia or for anxiety because of the side effect profile of this medication. Well, now you can see the difference between olanzapine and quetiapine. Okay, now let's look at clozapine, another second generation antipsychotic. Clozapine. So clozapine here. Clozaril. Now, Clozaril is the one most effective, the single most effective drug for schizophrenia. It's the most effective. If you're talking about antipsychotics, clozapine is the single most effective for schizophrenia. In addition, there is evidence that clozapine reduces suicide rate. Maybe even more than lithium. Maybe, lithium also does that. Lithium also reduces suicide rate. Yeah, so just like clozapine. But clozapine, apart from this, actually it also does treatment resistant schizophrenia. So if you've tried all medications and they have failed, clozapine will be a better option. If the schizophrenia is resistant to treatment, then clozapine. But before you go for clozapine, you must have tried. For schizophrenia, you must have tried olanzapine and risperidone before you can go for. It's not our first choice, but we are saying for treatment resistant schizophrenia. Now, we rarely use clozapine. Clozapine has deadly side effect. Has a deadly side effect. We are calling this agranulocytes. Agranulocytosis. This is when the white blood cells becomes depleted. White blood cells when white blood cells are depleted, what happens? Overwhelming infections, then death. So be very careful when you're prescribing clozapine. Be very careful do frequent blood work, do CBC, particularly A and C, particularly A and C. So, particularly A and C. If your A and C is less than 1,000 and your white blood cells is between 2,000 and 3,000, white blood cells, A and C. If your ANC is less than 1,000 and your white blood cells is between this value, please discontinue clozapine and monitor your patient for infection. It's deadly. It's deadly. So, not every prescriber prescribes clozapine. You have to go through some special training to be able to prescribe clozapine. But if you have the privilege of prescribing clozapine, make sure you frequently check CBC and particularly the ANC. If it's less than 1,000, discontinue. If white blood cells between 2,000, this one, discontinue the medication. Okay, that's why it's in as much as it's effective, we rarely use it. Then let's look at asenapine, Safris. Well, this is kind of the middle of the road antipsychotic. I wouldn't say it's not the worst or the best on any outcome. One thing that is significant about this medication is that its bioavailability decreases when it gets to the GI. So you have to give it sublingually. And then it interacts with serotonin and alpha-1 alpha-1 neuroadrenergic, and therefore they can be helpful in treating a mood disorder. So it's not the best or the worst, and interacts with serotonin and noradrenergic. So if they interact with serotonin and noradrenergic, it means they can be used as mood disorder treatment, but they are not as good, so they are not frequently used. And then its bioavailability decreases in the GI. So give sublingual. Ladies and gentlemen, thank you for being part of this session. In my next class, I'll look at the other group of second generation antipsychotic. I'll look at Risperdal and the other DONE antipsychotics. Until then, thank you.